morning, everyone. I would like to thank Dr. Unni and Dr. Manoj. Every time they do these conferences, they are really fantastic and wonderful. So my topic here is I'll be speaking only on the location of the cystoid changes in nature of treatment in DME. So we all know that accumulation of the extracellular fluid and the expansion of the tissue loss is the one responsible for the functional loss, and there is a predominant connection, interception between the inner and the outer retina, which usually causes significant impairment and consequent functional loss. So let's look at this situation both horizontally and vertically. So horizontally, we know that a very well paper, algorithms are published, and one written by Dr. Muna Bhende is very well established, the preferred practice patterns, that DME is now on the location, either it's a center involving or the non-center involving. If not center involving, then we treat according to the ETDRS guidelines based on the focal photocoagulation or the grid laser. Whereas if it's center, no vision loss, observe and treat. If it is due to vision loss, then go with the anti-VEGF therapy. So center involving is usually when the cystic spaces are involving the center of the fovea. They do have neurosensory detachment sometimes, and the central subfield thickness is more than 305 microns in women and more than 320 microns in men, as established on the spectralis OCT. So retinal thickening involving more than 3000 microns from the center of the macula but not involving the center of the macula is what is described as the non-center. So let's look at some of the examples. The central foveal large cystoid spaces, pre-injection, the patient vision was 624, and the post-injection we see it improved to 6.9 with good resolution. This is another type what Dr. Avinash was rightly speaking on, the hyperreflectivity inside these cysts. They usually indicate some chronicity, and also we see some hyperreflective foci in the hard exudates in the non-foveal area. There is a disruption of the ELM in these cases. So these cases are chronic and they are pretty resistant to the anti-VEGF, and this patient responded well with Ozurdex. However, there was only an anatomical response but not of much functional response in this case. So this was another patient, center involving. He had 6.9 vision initially. We gave anti-VEGF injection. He had a pretty good response with one dose, but he missed for follow-up. And later on, when we saw him after 6 months, there was complete resolution of the fluid. So that is what Protocol V recently very nicely has said, that when they categorized between the laser group, observatory group, and the aflibercept group, patients having good visual outcome in diabetic macular edema over the end of 2 years, there was no much statistical significant difference in between 3 groups, indicating that DME with good vision, the observation can be made. So in the non-center involving, we can see that either you can treat it with the focal laser or with the MPLT, and they pretty much act well if they are less than 400 microns. So this was the patient 4 months later, and 6 months later with the MPLT, he responded really well to the treatment. Now coming to these kind of cases where the cystoid spaces are in the ONL and in the INL, they are usually pretty much chronic, and of course this was the patient where we give Ozurdex. He responded well, and Ozurdex was out of circulation, and when the recurrence happened, we again gave him on anti-VEGF, but there was no much response in these cases. So when we look into the vertical assessment, it can happen at INL because of the leakage from the capillaries, either the SVC or the DVC, the ONL because of the disruption of the outer retinal barrier, and the SRF. So in this paper, very nicely said that cystoid spaces in the internuclear layer, they usually respond to anti-VEGF well, but however, they did show some recurrences. But whereas the cystoid spaces in the outer nuclear layer, they are pretty much slow to respond. Once they respond, they do have a status integro. So when we look into these papers, I think what kind of anti-VEGF or the steroid we need to use when they are involving either the ONL layer or the INL layer is pretty good. So another study looking at the OCTA on the non-perfusion areas, when we look into the left-hand side of the figure, when they cut it across in seeing the large cystoid spaces, in the DVC you can see here, there are a lot of capillary void areas. And this is post-treatment, although there was resolution in OCT, but still we can see some non-perfusion areas, and this is the comparative with the normal. So which indicates that the chronicity of the cystoid spaces, even though there is a resolution of edema, there is some non-perfusion still in the capillaries. So we need to differentiate between diabetic macular edema from the pseudophakic versus the cystoid macular edema. Here, the pseudophakic cystoid macular edema are usually in the inner nuclear layers, and they respond pretty well just with the PST injections. Whereas the diabetic macular edema, which can occur in the ONL and the INL, they usually require intravitreal injections. So mimicking as cystoid spaces, last 2 slides, is we should not forget in patients of DME presenting this tissue loss, they usually have a MAC tail, and of course the degenerative cystoid spaces, even though we treat them, they don't respond very well. Thank you very much.